I'm gonna start recording.
Hola, benvindo a nuestra presentación. We are so excited to present to you all today about a policy solution that we believe the Brazilian Ministry of Health could implement to address maternal mortality in Brazil. And I'm here with my group members, Ella and Natalie, as well as Julia and Nina, who helped with this presentation. We'd like to start our presentation with a story. Meet Maria, a healthy 24-year-old Brazilian woman who lived in a rural area and worked as a domestic worker. As you can see in this picture, Maria was pregnant and was expecting to have a baby. She had no birth risks, and she received some prenatal care through some of the existing government programs that work through local public hospitals in the area. She had no birth risks. Her fetus appeared to be healthy, but when she showed up to our local hospital with Braxton Hicks contractions, which are also known as false labor pains, her doctor scheduled for a cesarean section later that day, also known as a C-section. Now, before talking about what happened next with Maria, I'd like to zoom out and recognize that Maria is just one of many women in Brazil who receive a cesarean section. In fact, 54.7% of all pregnant women in Brazil underwent a C-section in 2013. In comparison, experts predict that only 15 to 20% of births medically require a C-section, and so this rate is quite high. As we go on to the next slide, we can see that C-sections have actually been on the rise in Brazil. And notably, they are not just localized to one area of the country. This increase spans across all areas of the country, including rural and more urban areas, and also spans all income levels. And so this truly is a problem that affects all women in Brazil. Now, returning to Maria's story, tragically, Maria, after having this unnecessary C-section, she developed a blood clot in her lung, which is known to be a complication from a C-section, and she ultimately died. And so once again, Maria is not alone. As we continue to the next slide, we can see that Brazil has an alarmingly high rate of maternal mortality among developed countries. Over the last 30 years, the maternal mortality rates have generally decreased due to new life-saving interventions and better government healthcare, but in Brazil, that rate has remained around today 55 deaths per 100,000 live births. Now, Maria had a couple of risk factors that increased her risk of maternal mortality, including that she lived in a rural area and worked as a domestic worker. It also is worth noting that Afro-Brazilian women are 50% more likely to die of causes related to pregnancy than are white women. And this risk is disproportionately affecting Indigenous and low-income women. Considering that maternal mortality, one of the risk factors is a C-section, we believe that this addressing C-sections is a promising way to lower this alarmingly high maternal mortality rate.
We would like to draw from a policy approach that was done in California, where initially 1/3 of annual births were completed via C-section. In order to reverse this upward trend, the government designed an approach wherein they changed reimbursement rates for C-sections so that compensation was less than vaginal births. This took away the financial incentive for physicians to do C-sections as much as they were doing. So they also launched a consumer campaign where they educated women on the risks and the complications associated with C-sections. And these two approaches took an increasing rate of C-sections, leveled them off, and now are on a downward trend. We would like to propose a three-pronged policy proposal that would hopefully allow the government to reduce the number of C-sections and therefore the rate of maternal mortality in Brazil. Our first idea is to restructure insurance reimbursement. Like the California approach, Brazilian health professionals should not be financially incentivized to perform C-sections. This approach would make reimbursement rates for C-sections less than vaginal births, removing the financial incentive. We also believe that you should redefine eligibility criteria. Only women who need C-sections should qualify for them. This would cut down on the unnecessary number of C-sections by making stricter qualifying criteria. However, it's really important to note that we want to emphasize equity here and ensure that women, regardless of race or socioeconomic status, have the same qualifying criteria for a C-section based only upon medical necessity. Our third idea is to educate medical professionals. Government public health offices should educate medical professionals on the risks of C-sections and when it is medically appropriate to use them. Since doctors are overusing this practice so much in Brazil already, this is evidence enough that doctors should be re-educated on the medical implications of the procedure. And we believe that these policies should ensure that Brazilian obstetrics can switch from using C-sections as a default.
Our proposed solution will be evaluated on 3 criteria. The first being political feasibility, as in how likely our solution is to be adopted by local actors such as the medical community and by Congress. We believe that because this is an informational campaign and a chance to cut public health care spending, it will be very politically feasible. In addition, local NGOs like ACMAN and CIOLA could aid in the additional training of medical professionals, especially in more rural areas without formal access to medical education. Considering the current leadership's opinion on expansion of women's healthcare, an educational campaign would be much more politically feasible than an alternative aimed at expanding women's healthcare, like access to abortion. Secondly, we estimated our proposed solution on cost effectiveness, or the cost benefit analysis per maternal death avoided. We found the solution would result in a net positive value, as the cost savings from reduced C-sections, which are more expensive to perform than vaginal births, would offset the cost of any additional training needed for medical professionals. The funds would be appropriated from national government and through your ministry and local NGOs to the areas assisting in intervention or public medical universities. The data we use, the value of statistical life, changes from agency to agency, but the latest estimations conclude it to be about $700,000 US. So as the maternal mortality rate decreases through our intervention, millions would be saved on behalf of the Brazilian government. Lastly, and arguably most importantly, we would consider the ethical frameworks surrounding our proposed solution. Like many Latin American countries, Brazil has a strong Catholic undercurrent for both its culture and policy. Instead of framing this as an expansion of women's healthcare, by framing it as the dissemination of information, it makes it more ethical solution on the properties of libertarianism, which supports freedom of choice foremost. Tied more so to the relationship of religion in Brazil, it is also more ethically conscious through the lens of moral objectivism and communitarianism. This harm reduction approach allows the community values and priorities to stay intact whilst also aiding with political feasibility and reducing the disproportionate rates of maternal mortality. With our proposed solution, women like Maria and other Brazilians will go on to live healthy, long lives as both mothers and citizens. Obrigada, and we hope you support our solution.